Hello and good evening, everyone. Welcome to our 36th Blue Earth Virtual Seminar. Blue Earth Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. I'm your host, Adam Getachew. I'm the co-founder and CTO at Blue Health Ethiopia. And it's a pleasure for me to have both Dr. Yitbarek Zeleke and Dr. Hailu Dhufera here. So I think this session is going to be a bit different in a good way from our previous virtual seminars. So we're going to have some kind of panel discussion, and Dr. Yitbarek is our moderator. I think I should leave the introduction. They should introduce what the session is going to look like, and also themselves. They should introduce themselves. So I leave the stage to Dr. Yitbarek. The floor is yours.
Okay, thank you very much, Adam. It's a pleasure to be a partner with you, and my greetings go for everyone who's participating in our webinar all over the world, and especially our first quality improvement session to be held in the live streaming will have been with Dr. Hailu, and so it's a great privilege for the young physicians who want to get into quality improvement also in public health. Therefore, I would like to welcome Dr. Hailu. It's Zeleke, improvement trainer, currently working in Addis Ababa Regional Health Bureau within Ras Desta Damto Memorial Hospital, and participating in different quality improvement activities with other non-governmental organizations, and also with the Addis Ababa City Administration Health Bureau. And so this is enough for my personal introduction, and I would like to invite Dr. Hailu for this webinar and introduce himself.
Thank you, Yitbarek. Thank you, the team. This is my first time on the platform, but I do know the activities this team is doing, and it is really inspiring. So I would like to say thank you for that. This kind of platforms are what we need to interact and exchange the knowledge, and also discuss really the topics that matters to the physicians, the clinical community. I'm Hailu. I am a physician trained in Ethiopia, Jimma University, graduated 2014. Then I shifted a career, moved into public health, and spent the past, I think now, almost 7 years in and out in public health around the Ministry of Health, but I did spend most of my time in school. I did a master's in global health, and I currently am doing my Doctor of Public Health. So this is my second year. I'm currently in US, Boston. I'm studying at School of Public Health in Harvard. And before coming here, I have been mainly engaged around quality improvement activities. So that is what I started on early on when I joined the ministry. I have been a trainer. I have worked as also a clinical governance and quality director in Alert, where I later worked as a medical director. So my life in public health have been revolving around quality, but I am also engaged in other activities, including health financing and related. So it's a pleasure to be here. I think as Dr. Yitbarek said, it's going to be dialogue. We are going to just discuss it. This is not a lecture. So I hope it will be interactive, that you put your questions or suggestions out there on the chats, or maybe there will be time for Q&A as well. Thank you. Back to you, Yitbarek.
Thank you very much, Dr. Hailu. Yeah, as it was already mentioned, that this is the first session for to be held based on quality improvement principles and concepts, and for introduction purpose, we wanted to be this session as a live discussion, open discussion format rather than the previous lecture forms. Therefore, this is an entry point for the subsequent quality improvement training is to be held on live sessions. Therefore, we are going to continue in this way, but I want to mention some of the areas or the topics to be discussed here. Therefore, the ground is for Dr. Hailu, even if we are going to mention the focus areas to be discussed here. Therefore, to start with, the concepts and an introduction or an entry for quality improvement concepts, I want to ask you that quality improvement in healthcare has a broad aspect, broad implications. Therefore, Dr. Hailu, would you like to introduce us what do we mean by quality improvement in healthcare, and what concepts should be understood for all healthcare professionals, especially physicians working in quality improvement or who want to get into quality improvement activities? Therefore, would you like to discuss a little about why quality improvement is the essence of quality improvement in healthcare? Also, what is needed to be understood by physicians when they hear the terminology about quality improvement in healthcare? Thank you.
Yeah, that is a very interesting question. I don't know, now you are currently actively training. Maybe you might have a different perspective currently, but maybe a few years ago, when we talk about quality among the clinical community, it is kind of regarded as some sort of political thing, or some sort of like useless activities that is going on, or what. Yeah, so there was a lots of understandings. There is a group that says quality improvement is something we really focus on, but the concept quality improvement is it is doing your thing in a better way and continuously improving that from what you learn from your journey. It is not, it's not only for health. Quality improvement is like for every aspect, whether it's your personal life or whether it is your academics, whether it's your work, your education, whatever you put in. You don't want to keep doing the same thing again and again if you are not getting the best result you want. And especially in this very dynamic environment where we function in, health is like very complex, so dynamic, and evidence changes so frequently, and whatever service we provide to our patients are tailored to individuals. And within this world, you need to kind of revolve how, like, you have to say, how can I do better? That is a concept of quality. And for equality, there are different like models, there are different names we keep mentioning, but the concept is just doing something in a better way next time. And how, like, there are process through it. How do you do that? How do you accomplish that? What I have to do, and how do I know that? There are process, I think we are going to mention them, but the basic concept I want to make it easy is like everybody would like to have a better thing. And we also, as a physicians or as a nurse or as any clinical service provider, even as a public health practitioner, want to provide a better thing with what we have. Quality is not about luxury, by the way. Usually there is that misconception of associating quality with luxury. No, it is not like that. Whatever you have, quality is not like you just have to have the at most available medical equipment. It's not having the at most. Yes, that is quality as well, but the concept of quality is if you are a general practitioner or if you are a surgeon, with your training and with what you have, the OR material, the difficulty, everything you have, what can be done to the most possible? Like how could you provide the service that is that you can do with the resource available at your hand? So that is a very plain language definition of quality, I want to say. But yes, thank you for projecting. The formal definitions are this. And the Institute of Medicine is one of the biggest institutions known defining quality so early on. They put the definition here, and the Ethiopian health system also accustomed from that. So basically, when we define quality, we tend to concentrate on domains. And the most common domains are like, is the service service safe? Is the service equitable? Is the service efficient? Is it patient-centered? Is it timely, which is really matter? So the domains are this, how we define it, but I think I'm maybe giving too much information here. We are going to go through them. And usually these domains are how we try to tolerate when it comes to health system. Back to you, Bill.
Thank you very much, Dr. Hailu. So for this, to start with this question, and we'll go in depth in.
Sorry, Yitbarek, you are sharing your screen. I mean, you are not sharing a slide, but you are sharing your screen.
Yes, yes. So I'm out of this sharing my slide. So just for the question to assist our audiences to take notes or to take screenshots of the concepts or the definition we are talking about. Therefore, this is a good standpoint to start with. Therefore, as a quality improvement expert, you have an experience in quality improvement training, developing quality improvement tools for the healthcare system in our country. By the time you have been actively working in quality improvement before you have moved abroad. Therefore, your experience in quality improvement and the dynamicity that you have thought that the healthcare system is dynamic, as everybody knows, and you have a deeper and maybe a different perspective that in this dynamicity of the healthcare system. So, as an quality improvement expert, what was your observation that quality improvement has been changed, or in the past few years there are some changes in quality improvement, and also different activities or different initiatives have been started in the healthcare system. What was your experience when you go into quality improvement? What was the change you have seen throughout your practice in quality improvement?
Yeah, thank you. As I said, there was a time where discussion about quality improvement was not that much of a big agenda, but I think we have progressed towards the point where now very senior clinicians, very exemplary facilities have been engaged in the concept of quality improvement. As I said, quality improvement is something that you do with whatever resource available to you. And I think we did come to that understanding, and the engagement in the clinical community has been amazing. Let me tell you, like when I moved to from ministry, I moved to Alert, and I was appointed as quality person, like the focal person, and no one was there before me. I mean, there was a reform team where the quality improvement related, especially Ethiopian hospital service strategic document, like EHSTG transformation guide was trying to implement. Before EHSTG, there was like EHIC, whatever.
Yes.
So they were doing that in the reform team, but when quality was separated as entity, I mean, they were trying to make it a unit. I was there, and I did try to talk to different practitioners. I did try like to recruit general practitioners. I did try to recruit nurse, midwives, because it has to be a multidisciplinary team. But it was so difficult. It was so difficult to convince anyone to come to work for this thing. And now I see in every hospital, like they have more than like 10, sometimes 20 teams, and most of them are physicians. And this is a big progress because here, like I just beside my school, there are lots of big hospitals. We hear their names in the medical books, like Brigham Women's, Boston Children's, General. There are big hospitals, and quality improvement unit is very strong in those big hospitals. Of course, they do have the utmost possible technology, capacity, everything, resource is at their disposal. But despite that, quality improvement is a big portion of their day-to-day activity. And I believe personally, especially in resource-limited settings such as ours, where you get to function possibly with sometimes literally close to nothing, quality improvement has to be there. So quality improvement could save life, could help you be very efficient, effective, and also even protect the professionals. Because one big part of quality improvement is safety, both patient and professional safety. You know, we work in a very hazardous environment. You know, they say like, if you spend significant time of your life, portion of your life, just flying with Ethiopian airline and just spending a day in hospital, your risk could be equivalent. Like hospitals or healthcare are risky. And unless we implement those scientific steps of improving quality and protecting both the provider and the patients, if you are not going to evolve daily towards like improving the possible margin of errors and continuously without blaming, without like putting this pressure on someone, quality improvement is not for punishment, it is for improvement. So unless we do that, I don't think we do have much to play with, especially with our resource. So yes, a lot has been done, and there is a lots of initiative coming from the ministry, coming from different organizations, non-governmental organizations working towards that, and engaging even to the primary level in the health center level, and it is promising. But a lot has to be done still, and especially the engagement of physicians. I think yes, we did a lot, we improved a lot, but still it lacks the engagement has to be increased. That is what I want to say.
Thank you again, Dr. Hailu. So you had a nice participation in you have seen the change or the dynamicity or the journey of quality improvement in our healthcare, especially in practicing the the Ministry of Health and also in other hospitals. That's a good experience to share for the fellow physicians. My next question should be, you have been participating in the development of these quality improvements, training materials in the guidelines also. So there was a selection of quality improvement models initially from our first question that we have been talking about quality improvement models, selection of quality improvement. I think for this first session, what we want our audiences to be aware of, to understand that what a quality improvement model is. So for the first time when quality improvement training was started, so it was based on a quality improvement model. And the materials were, or the training materials were also designed with, in line with that quality improvement model. So have you been participating, or what was your observation, or what was your experience in the selection of quality improvement models? And so can you give us a little discussion of quality improvement models, the selection? So as we know that the Kaizen and the model for improvement are being recommended for healthcare activities, both for public and other partner organizations, and also for non-governmental private facilities. So what was the reason for the selection, or what was your explanation? What would be your rationale for using model for improvement for the healthcare system in our country? That would be my next question.
Yeah, thank you. I think before I go to the model, it is important to talk about the science of improvement. So yeah, as I said, we would like to change things, both personally, professionally, whatever level, parts of our life, because we do better. We want to do better, and improvement is a science. So it is not, yeah, you know, we do know what science is. So it is something that has been proven, some things that has tested, some things that we know is going to work. So improvement is a science. And one of the basic principle in the improvement science is there is these two things that are very connected to each other in improvement, that is change and like improvement. So for an improvement to happen, like in Amharic, it's going to be, I think, mashashal, right? For an improvement to happen, we need to have some sort of change. If you want to improve your, I think that let's spice it. If you want to improve your salary, you know, this is a hot issue for us. If you want to improve your income, you need to do something. It is not going to improve by itself. It is not going to just out of blue, unless you get a lottery. Yeah, you are not going to afford a luxurious life, or what? Not luxurious life. You are not going to afford even the basic life unless you do something. So you need to do. There must be a change for an improvement to happen. Even like if you want to improve the inpatient mortality rate or emergency mortality rate, or whatever indicator you want to pick, you have to do something about it. So something has to change. That is what the improvement science says. But unfortunately, every change is not going to give you an improvement, because we have seen a lots of change in our life, like whether it is from structure-wise, whether it is doing something we thought is going to create a miraculous thing for us, but it ended up failing in it. So every change is not an improvement. So the trick is, what change is going to give me the improvement? That is what we need to identify in improvement science. And when we are doing quality improvements, that's what we need to identify. Like the fact that you started, I usually use this example, I think Yitbarek knows it. I want to, as I said, like I want to increase my income. I want to have a modest life. But the salary I'm getting is not going to push me that, and I decided to do something about it. So that something could be starting a side hustle, doing something at my free times, or it could be starting saving. Maybe I get to spend every day for like some amount of money for macchiato. I get to meet my friends, and we do some like talks while doing. So maybe sometimes in a day, I get to drink 5 macchiatos. So I decided to cut my macchiato expense. This is a change, right? I wanted to improve my saving. I wanted to have a modest life. I want to be rich or whatever. But unfortunately, every change is not going to bring that improvement I desired. So just let's calculate the number of macchiato I drink per day for a month. How much is it going to be? Is this going to be really significant amount of addition to my income that is going to create this modest life I dream of? Probably not. So that change is not working. So that change is not leading me to an improvement. So I need to decide to find another change. So maybe the side hustle change is working. Maybe the side hustle had added some couple of thousands or hundreds to my salary, which is going in the right direction. So basically, these two concepts are the change and improvement are a very tied concept in science of improvement. The other thing, talking about change, as Yitbarek has been displaying here, there are different changes as well. There are some change that is just instant and some changes that are really radical. Some things that are possibly impactful. We call them second order change. There are just first order changes. So you need to identify those kind of changes. Of course, we need them for improvement, both reactive, just a short responsive change, but we need to have a fundamental change, like those who are going to create impact for longer duration, which we are like going to create some sort of chance for us to reprocess things, redesign how we are thinking, how we are performing. So for this concept to be applied, we follow different models. If you go to different industry, you get to hear lots of models. Basically, model is how you frame your thing, how you are going to approach, how things happen. If you go to the Toyota industry, like company, they do have a model. I think lots of us could have heard about models like that are applied in Ethiopia in different sectors. Of course, you mentioned Kaizen, that is one model. Model for improvement is there, Lean is there, Lean Sigma is there. There are lots of models we keep hearing. But in Ethiopian situation, especially in the healthcare, the Ethiopian, the National Healthcare Quality Strategy, when the National Healthcare Quality Strategy was designed, two models were selected because all these models have been creating confusion. Even though the end result almost all the time is the same, whichever model you follow, I mean, suitability matters, but all these models are confusing, especially before the National Quality Strategy. If you get a training from organization X, and if you get a training from an organization Y, usually non-governmental organization, you get to experience different models that you can't utilize in your facility because you are talking different language. Because someone from the gynae ward could go for training in quality in my MNCH related project, and non-governmental organization X could train them using one model. Someone working on HIV will go for training with that is supported by organization Y will be trained another model. So this has been creating confusion among the colleagues in facility, and the language is very difficult. Communication is a big part of quality improvement. So the National Quality Improvement designing team decided to select two models, and the two models selected are model for improvement and the Kaizen. So model for improvement, I think we are going to discuss more about it, but to say a little bit about Kaizen, Kaizen is about restructuring your workflow. Basically, I think lots of us remember about Kaizen from news and TV, when they remodeled or restructure like the kitchens in the factory, or how they store things like in a big warehouses, like where they store significant like merchandise or what, and how they are doing in the dry store areas like Mojo and like that. So it is basically mostly applicable to restructuring your workflow, the physical structure. But Kaizen is not necessarily limited to that. You could even use it to restructure your thoughts, restructure your idea, restructure and whatever you want. So basically, these 5 S that are projected here are implemented in Kaizen. The first thing is sort it. So for example, go to your pharmacy, and in the pharmacy, we do have lots of medication, right? But all these medications, we don't use them that frequently. We don't use them equally like important or equally expiring or equally whatever like parameter you want to see. So based on that, you have to sort them. You have to standardize that. You have to clean the area, make it interesting, and you have to sustain that. So basically, Kaizen is for restructuring your workflow. But the model for improvement is the big chunk of our quality improvement concept. And the 2 models have been selected because of their ease of implementation. Especially model for improvement is something you can implement across every level of expertise. You can talk about model for improvement with a very scientific community. Actually, I'm recently taking a course that is here, and it is so complex. I have never realized model for improvement could be this complex. But you can also make it like very easily understandable. It is easily understandable, and it can be implemented even with farmers. There are some organizations who use model for improvement in agriculture in Ethiopia. So that ease of communication across every structure is one of the reasons it got selected, and we have been implementing these 2 models. I don't know if I go off topic, but please guide me, Yitbarek.
Yeah, you're just on the topic. Just I want it the model for improvement to come just a little bit in the middle or in the end of this session. Anyways, if you get into it, we can proceed into the model for improvement in much more detail rather than just distracting our audiences. So let's go into this model improvement. Let's finish your discussion already. You have started. So you can proceed with model for improvement, and I can share the slides also for the diagram for the model for improvement on our screen.
Yeah. So as I said, Kaizen is where you are going to use the concept of Kaizen is where you use to remodel or restructure or think about how you could create an efficient workflow environment around you. If your hospital is designed, most of the time it is, in a very difficult to navigate way, Kaizen is going to help you to do that. If your OPD or your inpatient or whatever you want to remodel, your room, if it is not efficient for you, or if the flow, like in the way you function around your environment is not comfortable for you, Kaizen is good to identify that. Kaizen is basically helpful in identifying and prioritizing something you need now, something you don't need, and something you need very occasionally. So something you don't need is waste, right? You don't have to keep it. You don't have to store it around you. Unfortunately, that is what we do. Like something that has never functioned in that corridor, have been there for the past 50 years, before you came, maybe before you even go to medical school, and still there, that is a waste. So what Kaizen tell you, get rid of it. Why do you keep it? But if it is something you are using it occasionally, maybe in 6 months once, okay, store it at the back, somewhere where it is not hindering your workflow, where it is not inhibiting you to function in efficient or effective way. But something that you are going to use, something that is very important to you, something that is happening, for example, antipians or flutes, bring them forward. Let them visible. And this is just one concept of looking into Kaizen. And sometimes we keep mixing things, right? That is also where Kaizen can be applied. Having the same bottle, size the same, color the same, labeling, not that readable, but very different medications. One like could create a very disaster if applied somewhere in some form, and the other maybe is okay. I do remember like magnesium sulfate and glucose, 40% glucose had the same bottling, the same appearance when I was in intern. And imagine like using magnesium for neonates, like mixing it like by mistake and using, assuming that it is 40%. That is where Kaizen should be there, like help you. So sometimes it looks like very luxury, why thinking, but not like that. So Kaizen could be used that way, but model for improvement is a big chunk, as I said. Model for improvement is basically about 3 questions and a PDSA cycle. So the 3 questions are whatever you want to change, whatever you want to improve in your life, you have to ask these questions. So the first question is, what are you aiming? What do you want to, what are you aiming to accomplish? What do you want to accomplish? As like, I could go to my example where I want to have a modest life. That could be what I want to accomplish. What is in your desire, like in your hospital? Is it surgical site safety, the infection? Is it like flow or rates, or is it morbidity or mortality? Whatever indicator, what are we aiming to accomplish? What are you trying to get out of it? So the first question is, what are we trying to accomplish? So you will know when you ask this question, especially quality improvement being done in a team, there will be lots of answers. Of course, we function in a system where we do have lots of shortage. We function in a system where we do have lots of problems. Like we can list lots of problems. So out of that, we are going to pick some, maybe 1 or 2 at a time. It is not about like changing the whole world at just right away. So we need to follow the next question. Okay, I want to do this. I want to have a modest life. What change can I bring that is going to give me that aim? As I said, it could be my side hustle. It could be cutting the expense of macchiato. It could be doing something else. What change can I bring? And when we ask these questions, still we could have lots of questions, lots of answers. Okay, let's do that. Mr. X did that. This had been proven or whatever. We could get that. And after that, as I said, every change is not an improvement. So you need to check whether that change you are saying is going to give you an improvement. So you have to ask a question, how do I know if the change I implemented is, if the change I brought is giving me the improvement I want? That is where you have to measure. My aim, my first question is, I wanted to lose 5 kilo in the next 3 months. I want to lose 5 kilo could be my aim. That's what I want to accomplish with my life. Okay, what can I do? What can I do to get 5 kilo? If I keep eating the same way, if I keep living the same exercise, level of exercise, are we going to get that magic of losing 5 kilo? Less likely, right? So what can I do? Okay, let's swim. Let's go to gym. Let's walk. Let's hike. There are change ideas there. But every change idea is not going to give us that improvement we want. We know a very fun thing about swimming. There are people who swim, but still have that big belly. Couldn't do any improvement with that. And we know who people keep walking, but not achieving the 5 kilo loss. And we know who people who hike and at the top of the mountain eating the burger. So which change is bringing the improvement? We need to measure that. That is the third question. The third question is saying, like, how do I know the change I brought is an improvement? So basically, even though this is a 4-day discussion usually, these are model for improvement. And the change idea you thought is going to work for you has to be tested in a cycle called PDSA. You plan for it, you do it, you study it, you compare your outcomes before and after, and based on the result from your study, you act, whether to proceed forward or abandon it, or maybe modify something about it. Hike, but don't eat burger at the top of the mountain. That is some sort of adaptation, like modifying your change idea. Oh, hike is not going to work for us, let's abandon it, another thing. But you have to test within this cycle. So basically, model for improvement is this. Back to Yitbarek.
Thank you, Dr. Hailu, for a very nice description of this model for basically, we are going to be recommended for using or implementing the model for improvement in Kaizen. Basically, you have told us, model for improvement can be used more efficiently in a scientific community, and the Kaizen can also be implemented in a production or in a process to modify our process in the production processes. That's very nice explanation. Thank you very much. So my next question would be, so in quality improvement, also in healthcare, performance are measured and day and night, from month to month, from year to year. So the concept of measurement in healthcare is also a big concept in quality improvement, yes? So therefore, what do we do with measurement in healthcare? And also, what is the importance of measuring in quality improvement, and what can we get, or what can we learn from measuring performances, activities, or collecting data in healthcare? Also, so can you give an explanation for our audience that how can we use, starting from the data and measurement, what can be the importance of this measuring in our, what could be the input of this measurement or quality improvement? Thank you.
Thank you. Yeah, I think, as I said, one of the components of quality improvement is measuring it. Because when we talk about measurement, we could talk about like a measurement that is used in a concept where you are trying to punish or you are trying to reward a group or an individual or even yourself. But the concept of measurement in quality is something different. So measurement in quality is basically, unless you measure, you don't know which direction you are going. That is why we need to measure. So as I said, if you want to improve in this direction, unless you measure, you can't just assume you are going in that direction. You could be going in the opposite direction and still keep working on your change idea. Like, as I said, if you are aiming to change your weight and your change idea is to go swimming 3 times a week, that is a big investment, right? 3 times a week swimming is not easy. You might pay for the swimming pool, you are going to spend time and all that. But after the swimming, if you are not going to measure how much you weigh every week or every day or every month, you don't know which direction you are going. You could be gaining weight, which is something that you don't want to have. So measurement is basically to know which direction you are going. And there are lots of indicators we use for measurement. But unfortunately, in our setting, most of the time we keep associating measurement with some sort of punishment. That is why the issue of data in Ethiopia health system is a very, very like something that we are not proud. There are lots of misinformation in measurement in Ethiopia. Whenever you ask someone to tell how they did or what they did, like whichever indicator we use, like we do have DHIS2 data gathering system. There are some survey kind of reporting systems. There are lots of indicators in HMIS. There is a lots of indicators we keep gathering, but those data are those measurements are usually misperceived, and of course sometimes used for a punishment or reward. So we associate measurement in, of course, yes, I am not against like punishing or rewarding. That is another discussion, but still measurement in the measurement concept in quality is for improvement. So we should advocate for measurement, but use it to change how we performed, which direction. If you are progressing well, keep doing that thing. If not, change it. Don't just keep repeating. So there is this proverb that go like, if you're going to do the same thing again and again without changing anything about it, it is stupidity. It is insanity. So that is how you prevent yourself from insanity. You measure and you know, and you follow the right direction.
Thank you very much, Dr. Hailu. So for our audiences to see the concepts reflected in Dr. Hailu's answers, so the screens I share are more related with the topic we are discussing with. Thank you very much, Dr. Hailu. For our next question for Hailu to be forwarded would be, every time to measurement concepts, the next would be quality improvement projects are the day-to-day or the performance measure for quality improvement teams. So in quality improvement activity, everybody asks about what's a project, how to do projects, and also what is the importance of doing projects. So is there another means that is frequently asked that could we have another way of improving our healthcare facilities or departments or service units other than quality improvement projects? So and the understanding of quality improvement projects should be clarified for healthcare professionals. Therefore, can you tell us that what a quality improvement project is, and also how do we do a quality improvement project? So what's the reason for being a quality improvement project, and what techniques should we follow to make a quality improvement project? And at the end, when quality improvement projects are ended in their activity periods, they are required or they are expected to be graduated. So when do we say that a quality improvement project is graduated? So these few questions could be related with quality improvement projects, and also from your experience. Also, you can add any related stories or experience to be shared for us. So you can proceed, Dr. Hailu.
Yeah, thank you. Yes, as I said, quality improvement is a teamwork, and it is a structured thing. So maybe we might have confused our audience because we are going all over the place, because this is a very wide topic.
It's broad, yeah.
Yeah, it is very broad topic, and maybe this is just an initiation of a longer conversation. I think that is how I see it. But
yes.
Quality improvement projects, because quality improvement projects are a teamwork thing, it is a structured thing. We have to follow that structure and work in a very structured way to test our ideas, to see if they are working or not, and to see if they are feasible to implement as well. Because, as I said, going through the models, once you identify your aim, once you then you identify your change, then you are going to test that change and measure as well that if that change is working or not. Then you have to see that and like give a conclusion. So there are different, I think we didn't discuss about how we conclude whether a change idea is now working or not. Is there are rules, like run chart is one of the simplest tool we use to decide whether our project is working or not. So based on run chart is basically, so for those who know statistics, you say whether your idea is working or not based on statistics. Like if I want to lose weight and keep swimming, but if I'm losing 2 kilos, is that enough? Is that good enough? Should I proceed? Should I decide to buy a yearly membership at the gym so that I keep swimming? Because is this thing working, or should I abandon it? How do you decide whether loss of 2 kilos or 3 kilos or 4 kilos is enough? Is good progress? So there are rules in the improvement science concepts that you apply. A very easy tools. Run chart has 4 tools based on those 4 rules. You get to decide. Then you say this project has led here, and if you tested it, usually quality improvements are started in a very small scale. You don't just test an idea across the whole hospital. You could test it in OPD, one of the OPD. You could test it in one of the inpatient. And if it's not working, you could also continue testing in another scenario, because PDSA cycle is like a revolving thing. It's not one-time thing. You keep testing it in a different setting. And after you realize that thing is working, after you develop some sense of confidence that the change idea is working for you, you move on to scaling it, maybe involving another 2 or 3 departments. Maybe if you are very confident, you could even move to scale it to the mass. And you have to sustain it. So projects are said they have done their job when they go through this cycle. And these cycles usually take time. And I say most of the time, even a small project could take up to 3 months, because there are data points we want to gather to decide on the run chart, usually more than 10 data points. If you are gathering every week, you are going to get 12 data points over 3 months. So yeah, it takes time, and that is when you say this project has done this and graduated once it gets through the phases.
Thank you very much, Dr. Hailu. So I want to continue more on quality improvement projects, because this actually, with this 1 hour or 1.5 hour discussion, it could be hard to cover all these 6-day training topics. It's known that, but to give a highlight of what the quality improvement training holds with, and also the aim or the purpose of quality improvement training should be introduced to the healthcare community, who are especially who are not involving in the private sectors. Therefore, that's why we need this webinar to be in this shape. So I want to continue with the quality improvement projects and the PDSA. So I'll go through the slides and share on our screen, and so you can go explaining these quality improvements and testing the because at the end point, every quality improvement team is expected to do quality improvement projects. So would you mind going through PDSAs? And so I can share the slides for PDSA. Thank you very much, Dr. Hailu.
Sure. So as I said earlier, once you identify your aim, let's go to clinical example. You wanted to reduce the emergency, let's say not emergency, or you wanted to reduce surgical site infection in your hospital. So that is your aim. That is what you want to accomplish as a team. So for surgical site infection to reduce surgical site infection, you talked about a change ideas. Few of change ideas could be you wanted to improve your hand hygiene. You want to check whether everyone is appropriately scrubbing right and all that. Or you could like say, maybe our sterilizing process has something. So you want to check that as well. And you could also say wound care, how we take care of our wound is problematic. So you want to check that. Or you could also say the ingredients we use, like the washing or whatever ingredient we are using, quality of that. So there are lots of change ideas, but out of this change idea, you picked one. Let us assume you wanted to change, you wanted to track how we wash our hand in preparation for surgery. And you wanted to track that. That is a change idea. So when you change that, maybe you decided from that, the best way to do it is X way, and the other best way to do it is Y way. So you just wanted to track that. That is, you set a measurement tool for you. The way to track it, it could be observation, whatever means you want to use. When you move to PDSA, you are going to plan for all this. So within your team, you just sit down, you are going to plan. For example, you are going to use this kind of soap for hand washing, and you are going to stick with that, and you are going to wash for this second, then you are going to that, you are going to next A, B, whatever procedure you want to follow. Then, after you planned, who's going to observe? Who's going to make sure? Who's going to remind everyone? Who's going to buy the soap? Who's going to provide whatever? You are going to plan for when, how, where, every details. And after plan, that is P, the P phase of PDSA. After plan, you move to do. The do phase is basically implementing what you plan. So our plan is to monitor hand washing, and we are going to specifically use this type of ingredient to hand wash, and we are going to do it in this technique, which we decided, we agreed as a group, this is a better change idea for us. This technique we selected, and you are going to execute that. But when you are executing this, you are going to document your observation. How did you execute it? It could be, you might have a shift, like shift A executed this way, shift B executed that way. That is your observation. This is not the time to manipulate. You just observe, you document, because you have already planned how to do it. Then you do it, you gather your information, collect your data. And the next phase is a study. The study phase is when you are going to sit down, see your data and compare. What did you do? How was it? Did we got shortage of our magic soap? Did we do all of us did that? We got shortage of water, or what? We got that every technique being implemented. You are going to compare, and here is when you are going to plot your data on a graph. The run chart I mentioned. It is, I believe, another time's discussion. If we have time, we might discuss later. But you are going to plot your data, and you are going to see how you progress. Did you progress towards your aim? What is our aim? We wanted to reduce surgical site infection. So you measure. So we implemented this. How did we do before and after? The study phase is where you plot your data on these run charts, and you are going to interpret your data. The data interpretation, as I said, you are going to use the four rules. There is shift, trend, and there is rule of runs, and there is astronomic. Basically, these are a clue where if you are going to have a consecutive 6 or more data above or below the median line, if this is confusing, just ignore it, because this is another discussion, a deep discussion that is required for this. But that is a clue. That is not going to be random. That is not going to be by chance. Statistically, we say p-value 0.05, whatever, right? We say there is not chance. It is the same. If a value you plot it with equal time, having 6 or more data points either above or below median line, there is not a chance. There is something happening there. That's something could be your hand washing. If you are implementing hand washing, something you change it, have brought it some sort of like shifts that happen. But that shift could be in the negative direction. While you want to reduce surgical site infection, it could increase surgical site infection, which is not random shift. Right away, abandon it because it is not working. It is getting things worse. The other rule is about trend. I'm not going to go in details, but those rules are going to help you decide and move to the fourth phase. The fourth phase is where you are going to act. So based on our interpretation, what did we learn? Did we learn something is working? Did we learn this could be something we can little bit adjust, maybe experiment it with shift B again and see? Or did we learn this is something we have to totally live? This is a crazy idea. Did we learn that? So we decide, we adapt, we modify, or we take it as it is. This is working, miraculous. We are going to take everything is working, we are going to adopt. If it is not, we are going to abandon. So the 4 cycles are this. I put it in a very rushed, plain way, but the cycles are this. But this cycle is not one-time thing. You keep doing it. To the time when you become very confident that change idea is working. It is all about degree of belief. We all know hand washing is going to improve surgical site infection. That is a proven thing, Harold. We all know. But is that our problem? Is that why we are having this high surgical site infection in our setting? We need to test it. We need to see it small by small. We need to use a different modality. Which soap or which technique is working better? And you keep doing that again and again to the point where you decide this is phenomenal. You are going to implement it. Your degree of belief is very high. Okay? We are going to use soap manufactured from this or this quality of our ingredient, or you are going to use this technique and decide on that and scale it and sustain it. You are going to standardize. From that on, you have worked like very long time to come to this conclusion. You are not going to risk it. You are going to say, this is our standard. Till the next bright idea comes. Till the next much better idea comes and knock out this. Though basically PDA says that. I hope I make sense.
Thank you, Dr. Hailu. Sorry for interrupting too. So can you add one point that to remind you that at the beginning of our discussion that we have said that quality improvements can be done at a minimum or at no resource settings. So the question comes here that when doing PDSAs, planning and doing phases. So on doing phases, there can be quality improvement challenges that are related with resources or reallocation of resource or financing of QA projects and other related. So what would be the advice for a quality improvement team when doing a quality improvement project and for testing change ideas, that what challenges can come when a doing phase is coming to action? And that's a question, and to remind you that only to include your answers for these PDCs.
Yeah, definitely there are challenges. As I said, we do have lots of problems. And these problems, when we put a solution, every solution we aspire to implement is not implementable. Either because the leadership is not willing, or because there is no resource, or because there is this person who goes in the opposite direction, or either because there is corruption, or there is lots of reasons. My advice is go for something that is in your control. Usually, we didn't discuss about prioritization, right? But when you prioritize something that is in your control. Because quality improvement is about doing a small thing that is going to bring a significant change. Don't just strive for the biggest thing. That is not in your control. So when you do that, like there is this 5 whys, or you could use the fishbone or driver, there are lots of tools we didn't discuss here. But when you do those, concentrate on something that is in your control, at least in the control of your team. Some basic things, because some of the very fascinating innovation in quality improvement can be done by doing a slight adjustment. Reordering things could change everyone's life. We all know the example of ATM, I think. By now, it is a very popular example, but I want to raise it. The ATM machine, initially, when it was innovated for reduction of this queue at banks, because people are there to withdraw money. There is a lot of people. So they decided they don't need people to come to bank. They could use a machine that gives them a simple order. But within a very short time of that implementation, this is a bright idea, right? It's an investment, whatever. But within a very short time, banks start to get crowded more. Complaint coming. And the complaint was a lot of people are losing their ATM card. They forget in the machine, and the machine takes it, and they have to come in line and asking for that again. The problem was the initial ATM machines, you give them your ATM card, you order your money, and they give you the money. Then, because our mind is programmed to go to the ATM to get the money, as soon as we get the money, we forget the card, and we leave. We don't forget the money. That is why we are there. As soon as we get the money, you could be rushing, you are in a hospital paying for something, you run away and you forget the card. And the card, if you are not taking it for a few minutes, it's going to capture it again. And the next time you realize you lost your card, you go to bank and complain. So what they did was a simple thing, just changing the order. Nowadays, most of the ATMs, not all of them, most of the ATMs, you give them card, you order your money. After they count, they did processing, everything, they will say, take your card. Unless you take card, I'm not going to give you money. So as soon as you take the money, put it in your pocket, they give you the money. You don't just take the card and leave. Actually, sometimes even when the machine didn't work and give you the card, you keep standing there for 5 minutes to make sure it didn't give the money to someone else. Because it is money and you are there to get the money. So this is a simple thing that significantly improved, saved billions of money. So when you talk about improvement, go for something in your control. And the sky's the limit when it comes to innovation. But still, I'm not saying we don't need to push the leadership, the financing, everything. We have to, but don't get frustrated with just the first time you engage in quality improvement. Don't get frustrated by pulling something up that is going to be just ending up on the desk or shelf somewhere. I don't know if I get your answer, but I wanted to say.
It's very good. It's very good. Thank you very much, Dr. Hailu. So as time is running for us, I want to concentrate on more on oncoming questions and questions from our audiences.
Sure.
Thank you very much. So my last few questions could be that quality improvement could be related with public health aspects, not only in clinical medicine too. So what is the relation between quality improvement and public health, and what is the importance of research in quality improvement? So I would like you to answer these two questions, and I'll go forward for the audience questions.
Yeah, this is actually one of the most frequent questions I used to get when I was training quality improvement, especially when there are senior physicians involved in the training. And I believe it is important to clarify that. So there is a difference between quality improvement projects and research. So basically, by definition, research means finding a new solution. That is research means, right? But of course, there are research that concentrate on improving the already existing evidence. That is also other parts of research. But quality improvement is not about finding a new idea. It is about doing things in a better way with the existing things, doing things in a much better way that is resulting in an outcome that you desire. So it's not necessarily generating a new idea. That is one of the differences. But the other difference is research are like they are going to take time. There are this ethical whatever process you have to go. It is going to be, methodologies, all those things. But when it comes to project, quality improvement project, it is something you do along your day-to-day activity. Just observe how you are doing and try to improve it. So there is a difference between that. But quality improvement projects are also a scientific results. If you did some quality improvement project, that is a scientific result that you can share with the scientific community. It is publishable. Actually, quality improvement projects are the most easily publishable things. If you do it right. Of course, I'm not saying like you just have to create a project and it's going to be end up on a big journal. But if you do it right, quality improvement projects are publishable. I really advise everyone who is involved in quality improvement project, because you want to share that, because it is a learning curve, it is a learning cycle, and someone should not necessarily repeat, if it is the same setting, should not necessarily repeat what you are doing in somewhere, and it could be very helpful. So it is really publishable. I really recommend for that, but you have to abide with the project cycle steps closely. So basically they are different, but they are also both where we are generating something that we can learn and something we can share for others as well.
Thank you for your good explanation, Dr. Hailu. So my next question will focus on introducing that quality improvement into the private sector. Actually, in our current information, that private facilities are getting engaged in time than ever in these facilities are more interested in involved in quality improvement. Therefore, I think that it is evident that our healthcare management or those who are leading healthcare in private sectors are more interested and are more trying to be engaged in quality improvement. But in the there is a big question that quality improvement is more on the shoulder of the health workforce rather than the healthcare leadership. Therefore, this is a big issue in the healthcare perspective. Therefore, what could be the role of the healthcare management and also other administrative authorities in quality improvement, especially in the private sector? That what's expected of healthcare leaders in private sector to integrate into quality improvement activities in their day-to-day practices. So this could be my next question. Thank you.
Yeah, those are the very important questions. Starting with the private engagement, I think the the private engagement, as you said, is improving. And it has to improve because there is a significant share of care in the private industry, and it is also growing, and it's going to grow. And that is very important. But I believe there is that gap between aligning this, like especially measurements wise, aligning with the public facilities. Like every tool that we use for measurement in public facility is not necessarily implemented in private. But if we see it this way, that because we said we are measuring to improve, not to blame, we have to be open. The private is also has to be open to measure their progress continuously and try to improve. That way, they are going to have a happy customer, and they are going to create a big contribution into the prosperity of the population. And definitely the private engagement is very important. It is improving, but still it is lagging behind. Because in the public facility, it's kind of an enforced one, but in private facility, you don't see that. Maybe I have been away for a few times, like now, I mean, not that very close. Maybe things have changed very rapidly, but still it is lagging behind. And the private engagement is a very crucial thing here. Even they could be a very much better leader on these innovative concepts, because we know in private, there is a better flexibility in acquiring things, because you don't have all those government bureaucracy. Solely owned organization is not as it is like in a government facility, and they could be a leader in this concept, and I really advocate for that. Coming to the engagement of leadership, management, the leadership and management, if any of you are in this as well, like hearing this, inform yourself. That is the biggest step you could do. Because, thank you for bringing this. For an improvement to happen, you need to have the first thing is, you need to be willing. And usually resistance originated from not knowing things. And that is a problem in our setting. Someone who is in a decision role, management role or leadership role, whatever name you give it, in a decision role, if they are not informed about this thing, they tend to resist. That is human nature. If you don't know this something, you will just say, you want to act cool and say, no, I don't think this works here. This is just fancy thing. We do have other problems. You create excuse because you don't know. So the best thing to do is inform yourself and advocate for that. All of us have to advocate, because most of us are leaders. That is why I'm saying most of us are leaders. But don't just take a corner and act as expert in everything. You can't be, no one can be an expert in everything. You could be the best neurosurgeon on this planet, but you can't be the best farmer simultaneously. Everyone cannot be best at everything. So just try to inform yourself a little bit. If you are in a decision role, that way, ideas are not going to be hindered. Ideas are not going to be inhibited. But unfortunately, we don't see that culture in our setting. Like in a very big size, we don't see that. So that is my advice. To build a will, inform yourself. And also try to be open, optimistic about things. Because sometimes some of the best innovation came from someone you have not expected from. Like the least expected individual, the least expected group could bring the best idea in your organization. So be open. So that is what we need to advise, advocate for leaders. And of course, accountability has to be there. Always accountability has to be there. Of course, like quality improvement is not necessarily by creating punishment and whatever, as I said earlier, but accountability also has to be there, and a system has to be created for that. I wish to see that day And it happens like gradually. It's not going to happen overnight. Back to you, Yitbarek.
Thank you very much, Dr. Hailu. You had a great explanation or the discussion of this quality and the management aspect of especially in our healthcare system. That's very nice and a clear answer that I gave, and hope that our audience also got the point here. Therefore, the other question would be, usually in our healthcare data management, this documentation of related evidences and also quality improvement project documents are usually are amended or are expected to be present on the day of supervision or evaluation on an external evaluator or some other body kind. So this is one of the questions from our audience is that the specifically that how can we avoid that documentation, or how can we embed quality improvement into our day-to-day practice? So what would be your recommendation for this?
Yeah,
thank you.
Thank you. I think that is also another important question. I know we don't have the whole day. I want to try to be like brief about it. That starts from the concept of the data, the concept of documentation. So, you know, basically what we do, we fabricate documents, right? I have seen a facility where I was for another purpose there 2 weeks ago, and all of a sudden there was a national supervision, and within two weeks, incidentally, I was sent there again. I mean, that was not the only facility I was sent to, but I was sent there again. And 2 weeks ago, I have seen like a lots of mess. I've seen like lots of things that is not functioning. But within 2 weeks, I was so impressed. They even had a fountain where there was fish swimming in. This is hospital I'm talking about. And it was crazy. I was so furious about it. But our concept of documentation and measurement is just fabricating it for the supervision, and that is after what the system could only capture. Then you could even get the prize. You could even get like some announced prize on whatever. But that shouldn't be the measurement purpose. As I said, measurement purpose is for improvement, for own thing. And that competition is not right thing. Of course, someone who did great, someone who did better has to be rewarded. But how we perceive measurement is deceiving us. It's distorting the whole concept of measurement. And it has to stop with me. It has to stop with you. So if you don't have it, you don't have it. Next time, try to integrate the things you work with your documentation. It is bulky. It is a lot. I complain about that a lot because the forms, the things you fill, it is a lot. It is so exhausting. That is what I used to believe. Oh God, Ethiopian health system has the worst, like lots of things to document, especially the nursing process and things to fill. And on top of that, you have to have protocols, whatever, just like on everything. But I recently shadowed a physician here in US in one of the, like in Boston. And I did realize we don't have that much documentation. We don't just have a system to integrate to our activities, day-to-day activities. We don't just have a system that helps us make it easier to document. So be innovative towards that. Of course, digitizing is the best thing to do, but till we reach there, be innovative. Try to incorporate every documentation with your day-to-day activity. Be very intentional towards that. That could be your project. That could be your quality improvement project. That could be the first quality improvement you could do within your team in a small scale. Just be intentional. Documentation is not for someone lazy. Actually, documentation is for someone who is very busy. Documentation is like not something you do next to taking care of patient. It is taking care of patient. We have to start that mentality. Documentation is not like because I'm busy, I can't do this. No. If you are busy, you shouldn't do things separately. Documentation is part of your thing. So that culture has to be there, but it is a journey that we are learning and we keep learning. So basically, that is what I want to say. That.
Thank you very much, Dr. Hailu. It's a great pleasure to have this discussion with you today. As this is our first session, I hope other topics or the topics we have gone through in rough will be discussed in detail in upcoming sessions. But for today, I'm not going to have any further questions, but to give you a last chance as time has gone. So if you have any message or what was your reflection of today's session, so I'll give you a minute and we'll go back to our hosts. Thank you.
Yeah, thank you. I see the time flies. So I might got so passionate. This is a very passionate concept for me. I'm so passionate toward it. Thank you for giving this chance to share. And I think we need to advocate for such a platforms. We need to do this again and again, rather than spending it somewhere else. Even though this is something we need to advocate. And thank you for the team for arranging this.
Yeah, this is the Blue Health team who has arranged this in accordance with the webinars. So we would like to thank the Blue Health team also. So I would like to again thank you for participating in our session. So I hope we'll meet again as time goes, and there are a lot of questions in this chat group. So in the coming sessions, specifically, we will save these questions and we'll try to address for the answers. I hope we'll meet again, and also we are going to have a more broad discussions and sessions. Especially, we'll try to invite other panelists also. So we'll meet again, and we'll be also on stage. So thank you very much, and for Dr. Hailu, for the hosts, and also for the audience.
Thank you for having me.
Thank you so much, guys. Thank you both, Dr. Yitbarek and Dr. Hailu, for this amazing, excitingly new session that you guys gave us. And from Blue Health also, we would like to thank both of you on behalf of both Blue Health and on behalf of our participants. We would like to thank you. I hope to see you in another setup, and even with another Zoom webinar like this. I hope to see you guys in the future. Yeah, thank you so much, guys.
Thank you.
Thank you, Adam.
All right.